We are now working under the 17th patch in the Medicare payment formula, which has been enacted over the last 11 years. This latest patch expires in less than a year on April 1st, 2015. We had legitimate reason to believe that this year would be different. We had a bill that both political parties supported in both houses of Congress. It had a smaller price tag than ever before, and it was an improvement in policy. It offered the following: incentive for practices to try new payment models. It provided bonuses for meeting certain quality measures and streamlined the reporting process. It had a provision that maintained fee-for-service with incentives to improve quality, thus avoiding disruptions to the provision of health care. It offered an evolution, not a revolution. We supported it along with the AMA. But when the time came for Congress to vote, each political party reverted to partisan jousting, and the bill did not pass. Therefore, we ended up with another patch, again postponing reconciliation of the SGR. Someday, I hope this framework will become law. I don't know when, and I don't know how. I do think we're going to have to take a different approach to ensure that the interest of 60 million senior citizens and military families are considered more important to Congress than the opportunity to score a few political points. The patch included in a last-minute addition a one-year delay in ICD-10. This was good news for smaller practices and mid-sized groups that are mostly independent and who are struggling to get ready for the deadline. ICD-10 is a leading example of many administrative burdens that have multiplied in recent years, both federally and here in Massachusetts. One particularly egregious example of bureaucratic overreach here in Massachusetts is the complexity of regulations proposed to register risk-providing organizations by the Health Policy Commission. Originally, this provision was intended as a way to help the state government keep track of the financial and organizational infrastructure of those taking on risk. Given all the alignment, mergers, and consolidations that have taken place across the Commonwealth, this was necessary. However, the regulations went far beyond those basic objectives. Instead, they required that the information was so detailed that even a large organization like Atrius Health said it would struggle to comply. We testified that this regulatory overreach would add to the cost of practicing medicine, possibly accelerating the consolidation of the healthcare market. This is ironic given the desire of some policymakers to put the brakes on proposed mergers and consolidations. Like much legislation, this regulation was drafted with little consideration of the unintended consequences. Every additional regulation takes us further away from actually practicing medicine. But this evidently was not a primary concern of those who wrote the rules. Another example of this bureaucratic overreach is that Chapter 224 ties our biannual license renewal to the demonstration of competency in the use of electronic health records. The author of this law insists that the utilization of an EHR is synonymous with improving quality and delivery of care. In fact, there's little evidence to support this notion or hypothesis. But that didn't stop the legislature from voting it into law while insisting on strict regulations to enforce it. It's strictly interpreted, this requirement would mean that unless a physician was personally certified for federal meeting use standard, he or she would not be licensed to practice medicine. Even in a state with one of the highest EHR adoption rates in the country, this requirement would require that more than 10,000 doctors would lose their licenses through no fault of their own. By law, many of them could never qualify for the meaningful use standards. Meaningful use was designed as an incentive program, not a certification standard. Establishing it as a proxy for our fitness to practice medicine is an egregious mistake. Implementing it in such a manner that would be catastrophic. Over the past year, we have taken two parallel paths to correct this error. The first is legislative. Change the law itself, either by repeal or significant revision. We felt we made a lot of progress in this regard a few months ago when the House passed good language in the mid-year supplemental budget. But the Senate didn't go long, and it died in the conference committee. The House added the same language to its budget proposal for next year, and we're hoping to work hard for its passage. The second approach is through regulation, and we've had some good news to report on that front. After many discussions with the Board of Registration of Medicine, the board has proposed an interpretation that does almost everything we could ask for. It introduces a long list of waivers and exemptions that will allow the overwhelming majority of physicians currently licensed to continue practicing. For a small group of physicians, there would be a requirement to complete 3 hours of CME on health information technology, but nothing more. The board also seems to be inclined to make this a one-time requirement, which means that you would not be required to recertify every time you're up for renewal. The regulatory process is going to consume at least a few more months. This includes a public comment period. We hope and invite all physicians to submit written comments. A strong physician turnout is essential in ensuring that good regulations are promulgated. I'm sure you've followed the stories about the controversial selection process for the medical marijuana dispensaries in the state. While we haven't commented publicly on this and don't plan to, we are quite interested in the medical marijuana certification that's already being done by physicians during the early stages of the implementation of the law. No dispensaries are open yet, but several physicians have already opened new practices that are solely focused on providing patients with medical marijuana and certifications. They have certified well in excess of 1,000 patients. And while it's legal to certify patients at this point, we do have significant concerns. The first concern is that these physicians may not be providing their certifications in the context of a bona fide patient-physician relationship, as the requirements require. While some may be evaluating the patient's complete medical record, they are doing so with the express intent of writing a marijuana certification and receiving a fee from the patient for doing so. This is not consistent with the accepted practice of medicine. I could not, for example, open a clinic just to prescribe oxycodone or Percocet. However, I could open a pain clinic where multiple treatment modalities are available, including oxycodone and Percocet. There's not a big leap from the practice of single treatment focus to the pill mills that we see here and there around the U.S. In other states, a small number of physicians have certified a very large number of patients. You'd like to think that this couldn't happen in Massachusetts, but how could we be sure? Can we afford to be complacent? There are a few other issues, such as the slow pace of the startup of registering these certifications on the database of the prescription monitoring program. When made operational, it would be easier to hold outliers among physicians accountable for their actions. Improving the PMP becomes even more important in light of the legislature's effort to address the increased number of opioid abuse cases in the Commonwealth. We had a very productive meeting with the Board of Registration and the Department of Public Health to discuss the issue of sole-purpose marijuana certification practices. There were some very constructive recommendations made regarding regulating these clinics. We also discussed some good ideas about the patient-physician education problem. To that end, we are holding a CME on June 18th on the clinical aspects of medical marijuana. The aim is to create a system that would make medical marijuana safely available in compliance with the law while treating it in the same manner as we deal with other controlled substances. Last fall, we launched an initiative to better inform physicians and their groups regarding ACOs and clinical integration. We had the help of excellent consultants in preparing manuals on the subject. Our team traveled around the state in an effort to clarify what clinical integration is and to outline to physicians how they can maximize their input in the governance and management of ACOs. There are some ways that we have been working on your behalf. These are some of the ways we've been working on your behalf. If this were easy, anybody could do it, but it's not. It takes persistence, focus, and dedication. There are some other issues on the immediate horizon, most of which deal with how we integrate and the scope of practice of allied health providers. And I think within the next week, you'll be receiving emails and asking you to comment and email or write to your senators and congressmen in the legislature on that regard. So we will inform you on that. So thankfully, we have an abundance of persistent, focus, and dedication. With your help, we will continue to make a difference on behalf of physicians and patients in this great Commonwealth. Mr. Speaker, that concludes my report.